Hello, my name is Mark Wallman. I'm the Program Manager for TB Control at the New Jersey Medical School Global Tuberculosis Institute at Rutgers University in Newark, New Jersey. So in TB, there are 4 priority TB control activities. 1, identify and treat persons who have active TB disease. 2, identify, locate, and evaluate persons who have been in contact with pulmonary TB cases and provide appropriate latent TB infection treatment or TB disease treatment as needed. 3, use targeted testing strategies to identify and treat persons with LTBI at risk of developing future TB disease. And 4, identify settings at high risk for transmission of MTB and apply effective infection control measures. So conducting contact investigations in the United States is one of the highest priorities for our programs. And obviously it's second in importance only to identification and treatment of TB disease. So a few definitions. What is a contact investigation? Well, it's a process to identify people who are exposed to cases of infectious or potentially infectious TB disease, to medically evaluate these contacts for infection or disease, and to provide appropriate treatment for contacts with LTBI or TB disease. It's important to emphasize that these investigations is not about simply identifying contacts, but also to medically evaluating them for LTBI or disease and following them through if treatment is ordered, following them through completion of treatment. So who are contacts? This is a very generic definition, but contacts are people who have shared airspace with a person with infectious or potentially infectious TB. These contacts may include household members, social contacts, co-workers, classmates, and others such as cellmates and shelter residents. So why is it important to conduct contact investigation? In other words, what are the objectives of the investigation? Well, it's to interrupt the spread of TB, prevent outbreaks of TB, and ensure appropriate treatment for LTBI or TB disease. And we do this by identifying contacts diagnosed with LTBI and providing appropriate treatment to completion of therapy, thus preventing future disease, and also by identifying contacts diagnosed with disease and providing appropriate treatment to completion of therapy, thus preventing further transmission. On average, according to CDC, 10 contacts are identified for each pulmonary TB case. Approximately 20 to 30% of household contacts are diagnosed with LTBI, and at point of diagnosis, 1% of contacts are diagnosed with TB disease. Who is responsible for investigations? Well, the state and local health departments have legal responsibility to investigate cases reported in their jurisdictions and to evaluate the effectiveness of these investigations. And so although health departments maintain the responsibility legally, some of these steps may be delegated to other sources, such as in a worksite exposure, occupational health officers may be involved. If it's a hospital exposure, infection control practitioners may be pulled in for assistance. So we're going to discuss now some of the core concepts and skills required for conducting these investigations. So it's important that interviewers have a knowledge of TB transmission, have a knowledge of TB pathogenesis. They need to understand the difference between LTBI and TB disease. They need to understand the risk factors associated for progression from infection to disease. And of course, interviews need to have effective interviewing skills. We're also going to discuss very briefly data management and analysis skills. So as you know, transmission is defined as the spread of an organism, such as TB, from one person to another. The mantra in TB is every TB case began as TB contact. So it's important that everyone understands as interviewers how important it is to identify as many contacts as possible, contacts who are considered to be high risk contacts. Today's TB contact could be tomorrow's case, but today's case was definitely yesterday's contact. So when a person with infectious TB disease coughs, sneezes, speaks, or sings, tiny particles, droplet nuclei, are expelled into the air. If another person inhales that droplet nuclei, transmission may occur, and the operative word here is may occur. It's important to remember that not everyone who is exposed to TB gets infected with TB. Remember, only 1/4 of the people exposed, approximately 1/4 of the people exposed, are infected with TB. The probability that TB will be transmitted depends on the following factors: the level of infectiousness of the index case, the duration and frequency of exposure, and the environment in which exposure occurred. So regarding the index case, some of the characteristics associated with infectiousness is respiratory TB, that is TB of the lungs, airway, or larynx, the presence of cough, a positive sputum smear, cavitary disease on film, positive cultures not covering their mouth when coughing, not receiving adequate treatment, and of course undergoing cough-inducing procedures. We shouldn't forget that a patient with a negative smear does present the potential of transmitting. Regarding the duration and frequency of exposure, contacts at higher risk for TB infection are those who frequently spend a lot of time, quote unquote, with the index case and have been physically close to the case. A lot of time is a very general term, very difficult to define, but state TB control programs or local programs really develop their own criteria as to who is a high-risk contact based on hours of exposure. There's no standard, there's no cookie-cutter approach. It is a local program decision. Regarding the environment of where exposure occurred, the environmental characteristics that increase chances of TB transmission usually are found in small, crowded rooms with poorly ventilation and rooms without air filtering systems. So essentially, we strive to stop the train of transmission, and the best way to do this is to identify and isolate infectious or potentially infectious patients and start effective treatment. Regarding pathogenesis, as you may know, pathogenesis is defined on how an infection or disease develops in the body. So what happens when someone is actually exposed to TB? Again, not everyone exposed becomes infected. However, persons who become infected would generally have a positive tuberculin skin test or an IGRA, and persons who are infected can either be diagnosed with LTBI or active disease. LTBI really is when the immune system surrounds the organism. If the immune system is healthy, macrophages surround the organism and build a wall around it and do not enable the organism to multiply. The characteristics of this diagnosis is the TST or IGRA is usually positive. The patient who is diagnosed with LTBI is not considered infectious. The patient is asymptomatic, typically has a normal X-ray, and if sputums are collected, the smears and cultures are typically negative. And obviously, LTBI is not considered a case of tuberculosis. However, TB disease happens when that wall that surrounds the organism breaks down and the organism starts to multiply, leading to active disease. Typically affects the lungs, but can affect other parts of the body. In the United States, approximately 85% of TB cases are pulmonary TB. The remaining are extrapulmonary TB. The characteristics usually include a positive TST or IGRA, typically infectious before treatment. Patients may have symptoms, looking for a cough primarily, will have an abnormal X-ray, and positive smear and cultures. Smears may be negative, culture may grow MTB, and this individual is considered a case of TB. Regarding extrapulmonary TB, these other areas may include lymph nodes, pleura, the brain, kidneys, or the bones, and typically they are not considered infectious or contagious. So what are the general symptoms of TB disease? Cough lasting for several weeks, coughing up sputum or blood, fever, chills, night sweats, weight loss, loss of appetite, fatigue, malaise, and chest pain. Typically, pulmonary TB patients typically will have a cough, but not all patients do cough. You can see where these symptoms mirror the flu, which makes TB sometimes very difficult to diagnose in the practitioner's office. This table summarizes the difference between LTBI and TB disease. On the left, LTBI, the tubercle bacilli is in the body, but it's walled off by the immune system, causing no multiplication and no disease. The TST or IGR is usually positive. X-ray is usually normal. If collected, sputum, smears, and cultures will be negative. The patient is asymptomatic. The patient is not infectious, unable to transmit, and obviously is not considered a case of TB. On the right-hand side, TB disease, which is, we'll talk about TB in the lungs, which is pulmonary TB. The bacillus is considered active in the body. IGRAs or TSTs are typically positive. X-rays typically abnormal. Sputum smears and cultures are usually positive. Again, the smear can be negative, but the culture would grow MTB. Symptoms such as cough, fever, weight loss will be present, but the main mechanism of TB transmission is through coughing. And the patient is often considered infectious before treatment, and obviously this would be a case that's reportable and as a case of TB. Some of the conditions that increase the risk of progressing to disease once infected, I'll just highlight a few items. On the left, children younger than 5 years of age. Obviously, the immune system is not fully developed. Weakened immune systems, HIV, diabetes, certain types of cancer, any patient who is on immunosuppressive therapy. On the right-hand side, X-ray findings would be suggested of previous TB, low body weight, and recent infection within the past 2 years. And cigarette smokers and persons who abuse drugs or alcohol. The risk of developing TB disease is highest in the first 2 years after infection, or if foreign-born, the first 2 to 5 years after immigration. Patients with diagnosed LTBI can be treated to prevent development of TB disease. The diagnosis of LTBI early and providing treatment helps prevent new cases of disease. And that is one of the key goals of contact investigations: identify LTBI patients, prescribe treatment to prevent future disease. Regarding effective interviewing skills, effective interviewing skills are essential for identifying information or eliciting information from cases and their contacts. Skills can be taught and improved with practice and time. There are self-study modules available from CDC regarding interviewing skills. These materials can be accessed via the CDC website, www.cdc.gov/TB. And finally, data management and analysis skills. Collecting data and analyzing data helps determine the effectiveness of contact investigation efforts. For simplicity, it's best to keep the database simple, such as TST, IGRA results, treatment status, how many contacts were identified, what the findings were of the contacts, were they diagnosed with LTBI, TB disease, how many contacts started and or completed LTBI treatment. So the simpler the database, the better.